Hello, Prof. Good
Hi.
morning.
Good morning. Good evening. I'm glad I made it. I was rushing as best I could through rounds.
Yes, thank you. Thank you very much.
You're quite welcome. 20 patients this morning, but I got them all seen. Okay. Yeah. Well, it looks like you have a nice crowd today. And I've divided today's lecture, well, this subject into two parts because it's too long for 30 minutes. Fecal incontinence. So whenever you like, we'll get started.
It was fecal incontinence, but whatever you like, it is okay for us.
Yeah, I have the fecal incontinence ready to go. I think just that, yeah, whenever you like, talk about fecal incontinence.
Anything you like. You are the
Okay,
best judge.
thank you. That's what I have ready to go. So I can share my screen. And, I think the first thing to say is when we think about fecal incontinence, we have to kind of divide the treatments. And there's a few ways to look at it. You could augment the sphincter and augmentation. I'm getting a little echo from the room, I think. I just lost the room. Could they still see me?
I'm there.
Okay, perfect. Okay, as long as they can see me. Okay. So first you can augment the sphincter by injecting something into it. You can repair the sphincter. You can repair it. You can replace it with something like an artificial bowel sphincter, a gracilis muscle, a stimulated gracilis muscle, a magnetic anal sphincter, a sling. So you can replace it. You can stimulate it, like sacral neuromodulation or posterior tibial nerve stimulation, or you can bypass it, which means a stoma, whether a continent stoma or a Malone antegrade colonic lavage type procedure. So those are the five basic ways that I think of incontinence. And I wrote that as an editorial in The Lancet maybe 5 years ago, where I use those five categories as I think are very, very helpful. And I didn't reference the Lancet article here, but you can certainly see it. So let me share the slides with that introduction. Expand this to get to share screen, and this one, and I'll go to full screen. So can you see my slides there?
Yes, we can see. We can see your screen.
Okay, perfect. So let's start out with injectables. To augment the sphincter, augmentation, there's a variety of materials that have been used with reasonable improvement in scores, anywhere from 30% with bioplastique to Ahmed Shafiq in Cairo, 85% improvement. We did a study here with carbon beads, and we failed to get the score below 10, which is really a break point in quality of life. There's multiple studies showing a statistically significant correlation in quality of life if the incontinence score is above or below 10. And that's been validated in about 40 languages now. So we didn't achieve it in that study. The only one that did was Joe Chandra from Australia, who looked at PTQ. Most of these don't have that robust a result. Some of the newer ones do. Here's another PTQ study. Miranda Chan took over the practice from Joe Chandra after Joe unfortunately passed away, and again found she dropped the score from a 10 down to 6. Oliver Schwander, one of our alumni from Cleveland Clinic, Florida, working in Lübeck, Germany, looked at hyaluronate, the same substance used in Ceprafilm for adhesion prevention, and did not achieve that breakpoint of 10. There's a systematic review looking at these things and pegging the long-term success. Again, PTQ perhaps at the top of the list for any large, none of them are terribly large, but 21 studies, relatively low morbidity, generally relating to the injection itself. There was a slightly newer review from one of our alumni, Lucia Oliveira, and a couple of others from the Austral Hospital in Buenos Aires, Billy Rosato, Pablo Piccinini, and Karina Twat, looking at this bulking agent that they have, which is, I think they call a sphincter, as opposed to Carlo Ratto's device of gatekeeper. And you can see they had 58 patients with a mean score ranging from 6 to 12. They define success, as we did previously in many studies: artificial bowel sphincter, stimulated graciloplasty, sacral neuromodulation, 50% or more improvement in the incontinence score. And they found a 60% success rate, which is reasonable. None of these success rates are going to be 100%. So the important thing is there is a corollary improvement in quality of life. And Carlo Ratto's is similar to the sphincter. So I may have gotten them backwards. Maybe the South American is gatekeeper and this one's sphincter for the trade names. But this one's a different material. This one has they're long dehydrated solid cylinders, which have a shape memory. And as they come in contact with body fluids, they expand. And Carlo initially did a series of 10 patients. You can see these little round implants that are placed with a little kind of a gun, almost like a drill, to put them in. You can see how they're put around the anus. And he, shows how they go in the intersphincteric space. So you want to put them between the internal sphincter and the external sphincter, a whole lot of them. And he found that there was one partial dislocation, but otherwise no reported complications. And as the series grew, and Carlo Ratto reported more recently in British Journal of Surgery, the Cleveland Clinic incontinence score baseline was 12. And then, unlike other treatments which wane over time and the efficacy decreases, what he found is the efficacy increased after that initial period, maybe because of tissue remodeling from having these devices in place. So there were statistically significant improvements in soiling, incontinence to gas, liquid, and solid, and in the overall Cleveland Clinic, Florida incontinence score from 12 down to under 8, which again does correlate with the statistically significantly improved quality of life. So here's how it's done. I mentioned it's a little like gun or drill, and you can see on an endoanal ultrasound what it looks like with these implants in place. And he noted increase in squeeze pressure, increase in resting pressure, and contractility was better too. So it's kind of mysterious as to how these things work, but they are available, that they're commercialized, unlike a lot of the other devices that we have. Here's how it looks like before and after sphincter. So before and after, you can see the echo shadows on both of these images of all of these devices in place. So there's about 8 of them placed here, 8 or 9 placed, and that really gives this improvement. But there are other ways to do augmentation. 10 women from obstetric injury using autologous skeletal-derived cells into the external sphincter directly. Again, improvements in the incontinence score. Johann Pfeiffer, another one of my alumni, is in Graz, Austria, found improved quality of life, improved pressure. So another way to do it was with myoblasts. This study from France, phase 2 study, using either the autologous myoblast, muscle cells, or placebo, and found that the score decreased in the myoblast group from 15 down to 9, again, breaking through that barrier of 10, whereas the placebo group only got to 10 from 15. And very importantly, at 12 months, like we saw with Carlo Ratto's device with the sphincter, the score is even better. So it was 15 initially, dropped to 9, ultimately got to 6.5, just like we saw with Carlo Ratto. So again, unlike sphincter repair, which I'll cover ultimately with you, unlike sphincter repair, which wanes over time, these procedures for augmentation get better over time, presumably as we have tissue remodeling. Another way to do it, and it's not commercially available, but I understand some people are figuring out how to do it, is radiofrequency. Radiofrequency is a tissue remodeling where essentially radio energy is delivered to the internal anal sphincter, not so much the external. And you can see improvements in quality of life, decreases in incontinence score. The studies that were from Cleveland Clinic, Florida, that study, this study, and this study, not dramatic, not as good as we see with SphincKeeper or with autologous myoblasts. But we know how it works, which is interesting. So this is a study we did with 12 female pigs. 8 underwent radiofrequency 6 weeks after the induction of fecal incontinence, which was basically muscle damage. 4 animals were untreated and 4 more served as control. We then had 2 blinded pathologists look at the tissue and found that radiofrequency actually induced morphologic changes in the sphincters. So basically, the radiofrequency treatment resulted in less collagen and more muscle after that energy delivery. So if we move on from sphincter augmentation to sphincter replacement, one of the treatments I think is outstanding, but again, it's not FDA approved, it's available in other countries, is dynamic graciloplasty, where we take the gracilis muscle from the leg, we transpose it around the anus, and we then put in a stimulator to help convert the muscle from a twitch muscle to a tonically contractile muscle. So you can see we're creating a new sphincter here. We're not wrapping tendon, as the artist shows, Lois Barnes shows in Corman's textbook. We're not wrapping tendon. We're wrapping muscle. We're only anchoring the tendon to the contralateral ischial tuberosity, or sometimes the ipsilateral ischial tuberosity. And then we're putting on a stimulator so this muscle becomes tonically contractile without fatigue and without pain. And that's a dynamic graciloplasty. And the way this device works is that the anus is closed because the device is delivering constant energy. And when the patient holds a magnet over the stimulator, it relaxes. And when they put a magnet again, it closes. It's a fascinating technology. We looked at it, this is a very old study, almost 30 years old. And we used to do a 3-stage procedure because we did a vascular delay of the muscle to let the muscle hypertrophy. Then we went back to harvest and transpose the muscle. Then we stimulated it. A lot of complications, though, high complication rate. Here's another study from your neck of the woods, as it were. Retrospective, all patients became continent with an improvement in quality of life. So whether North America, India, similar results, but unfortunately a very high morbidity rate. As you can see here, this study was from my unit. This one obviously was from my unit too, depending where in this one I participated in. So the success rates are pretty robust, nothing below 50%, except this green line here, which was a unique type of stimulation we tried. But with our standard stimulation, again, we fell in with the pack, 56 to 93% success, but morbidity, when reported, 42 to 77%, and revisional surgery up to 77%. So a complex, difficult, challenging procedure. The artificial bowel sphincter, and again, this one may be making a resurgence, another fascinating technology. It's like the artificial urinary sphincter. So there's a little cuff that goes around the anus, distal rectum, lateral to any existing muscle, and high up by the puborectalis, not near the skin where it'll extrude. That cuff generally holds anywhere from 4 to 7 cc's and is connected to a little pump that rests either in the labus majorum or the scrotum. There's a reservoir in the space of Retzius that holds the rest of the fluid. And basically, this cuff stays closed. And when the patient wants to evacuate their bowels, they squeeze this little pump. And every time they squeeze it, half cc of fluid goes out into the reservoir. So it empties. And over the next 3 to 5 minutes, the patient can evacuate their bowels while the sphincter slowly closes as that fluid re-enters the cuff. So fascinating technology. 3-part balloon, cuff, and pump. And again, here's our series here. And you can see infection rates very, very high, unfortunately. Explantation rates not as high, but most of them still functioning with improvements in incontinence score and quality of life. Magnetic anal sphincter, another ingenious way to try to give continence. It's basically almost like a bracelet. that goes around the anus. You can see here, and it expands. So it opens and closes when the patient moves their bowels. The magnets hold it together, and then when they pass their bowels, the magnets come apart from having that bowel movement and then go back together again. The person with the biggest experience in the world was Paul-Antoine Lohr from Nantes, France. His initial feasibility study showed a dramatic decrease in weekly incontinence episodes, tenfold reduction in incontinence, with a major decrease in incontinence score from 17.2 down to under 8. Again, going along with a dramatically improved quality of life with far less complications than either the stimulated gracilis or the artificial bowel sphincter. Long term, you can see what it looks like being implanted here with the little magnets. 7 device explantations. So not without its problems, certainly, but a good option to improve incontinence when it works, because ultimately the therapeutic rate, even at 5 years, was over 50%, which, of course, as I've mentioned several times in this lecture, goes along with significant improvements in all 4 scales of the fecal incontinence quality of life instrument. There's a lot of domains, but the 4 of them relating to quality of life. Again, nothing's perfect. There's a lot of morbidity with these things. But you can see ultimately graphically how that worked out with 50% or more reduction in fecal incontinence episodes, less than 50, but still better, and then explantar stoma. So, more than half of patients did really, really well. Looking at it another way, you can see prior to surgery, weekly incontinent episodes dramatically decreased. In days with incontinence, dramatically decreased as well. Cleveland Clinic incontinence score from 16 down to close to 6. And then the other one, I'm saving the other technologies for the next lecture, or the other techniques for the next lecture, is instead of a regular stoma, because I said the ultimate possibility, if you can't do or patient fails, augmentation, replacement, repair, stimulation is bypass, and bypass means a stoma. But instead of a colostomy, the other way to do it is to try and make a continent appendicostomy, or using the small bowel with a bishop coop configuration, creating a spout that the patient can irrigate and have antegrade evacuations. But ultimately, the one thing that may be in reserve for everyone is a colostomy for fecal incontinence. So again, I've divided it in 2. Today we covered augmentation and replacement. Next time we're going to look at repair and stimulation. The other 2 alternatives, well, bypass I put in here too very briefly. And again, I'm hoping that along with the Indian Association of Surgical Oncology, I see a lot of you in Jerusalem. We are going to be having scholarships for people to apply for financial assistance to attend this Congress. And as always, you can scan the QR for the information, and we're accepting abstracts for the meeting as well. Have poster presentations at the meeting. So I'm glad I was able to start on time and save a little time for some questions.
So thank you, Prof. It was a very nice presentation. So
Thank you.
anybody in the audience, do you have any question? Yes.
There's injectable method, right? Where is exactly?
Shadab,
Yeah.
can you come nearer, please, so that we can listen to you? Please, just little bit. Yes.
Yeah, I'm just asking. There's injectable, how we can inject the injectable methods. So what is exactly injected? There is a difference. Thank you.
Did you hear?
No, I didn't.
Shanu, Dr. Shanu is there.
Yes, sir, I'm here.
Please just explain near the mic. What is her question?
Come just be little near.
Yeah, hi, doctor. Thank you for the lecture. Are you hearing me?
I can hear a little bit, yeah.
Yeah, okay. So I'm just asking about what is your technique on injecting the injectable methods. So if there is like specific site where you are injecting.
I must say it's
Dr.
not clear.
Shanu, speak loudly. Repeat.
Maybe or repeat the question. Somebody
Dr.
else.
Shanu, repeat it.
So the question is where he injecting the injection and what is the technique?
Call Dr. Shanu with WhatsApp business.
Can you repeat it for me, Dr. Mishra? Because I can't hear it.
What is the question? What is the question? First,
So I'm just asking where is he injecting exactly the injectable method? Where's the site where he's injecting? And if he can tell us like a small clip.
Okay. Okay, her question is where actually you are injecting in injectable method of the treatment of incontinence, and if you have any video to show the site of injection.
Yeah, I don't have a video in this talk. I can certainly try and get one for the next part if you like. I have videos on all these things, but that would be multiple
Okay,
more
just
lectures.
if you can explain like at the
Yeah.
place where.
Yeah, trust me, I have videos on every one of these, but I had to limit the time. Basically, the intersphincteric groove is where both the Rosato study using the gatekeeper and the Ratto study using the sphincter intersphincteric groove. So it's basically just like you're going to do a sphincterotomy. You identify the intersphincteric groove and you inject between the internal and external sphincter. Now, radiofrequency is delivered to the internal sphincter when you deploy the prongs of the device. And again, I can show that video if people want. I can extend this to a third part and we can do technical videos if you like. The other one is the autologous myoblasts, which tend to be injected into the external sphincter. So it depends which injection you're doing. Myoblasts go in the external sphincter. Fat has been used in both the intersphincteric groove and the external sphincter, radiofrequency in the internal sphincter. So it depends a little bit. And again, if you like, I absolutely can prepare a session of technical videos for these things.
Okay, so I will demonstrate them, Prof. I have your videos. I will demonstrate them. So thank you very much.
Yeah, I have. Just be sure you have all of them because I have videos on stimulated graciloplasty, artificial bowel sphincter, injectables, radiofrequency, sphincter repair. All of those I have. I do not have one on the magnetic anal sphincter, but I have all the others.
Okay, thank you very much for your valuable time. Thank you very much.
My pleasure, and I'll see you again next month. Thank you.
Thank you.
Bye.
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 So I will demonstrate you the techniques in the next lecture. So how many of you have already done the robotics? Only few. So now we will it will be on up to 6:30. Robot will be on. So please one by one just practice the robot.